Now, ventilators used to only be seen in ICU settings, so you didn't see them asked about a whole lot on the Nclex because it's not something that an entry-level nurse needs to know about. But now you have ventilated patients all over the place. You have ventilated patients in long-term acute care hospitals. You have them in home health settings. And these are patients who are going to be on ventilator potentially for the rest of their life. These are people who are conscious on ventilators. You can go in and you can talk to them. They may not always be able to talk back to you, obviously, since they're cannulated. But these are people that are conscious a lot of times. So we need to be able to know a little bit of stuff about ventilators. You don't need to know what a respiratory therapist knows, but when the alarm starts going off, you're going to be the one who's going to be there first, most likely, and you just need to know some of the basics. So they are typically going to be going off and beeping for one of two reasons. One is a high-pressure alarm, and the second is some type of low-pressure alarm. The high-pressure alarm, they're triggered when there's an increase in pressure. Okay, so high-pressure alarms are triggered by an increase in pressure, and they can come from any one of typically about three reasons. Number one is there is a kink in the tubing. So the tubing's folded somewhere, or the tubing is smashed somewhere. Sometimes it could be you rolled the bedside table got rolled onto the tubing, or it got clamped in a bed rail, or the head of the bed was lowered onto the tubing. That can cause the kinking. The second time that there is going to be pressure buildup, right, is when there's water in the tube. So imagine taking a garden hose, and if you were trying to blow through that garden hose and it was empty, you're not going to have too difficult of a time blowing through there. But if that garden hose was half full of water and you go to try and blow, you're going to have a lot of resistance. Same thing if there's a kink in that tubing. You're going to have difficulty blowing through. So as the machine recognizes that increase in pressure that's required to get the same breath and the same level of ventilation in that patient, it's going to alarm. So the first thing is a kink in the tubing. The second thing is water in the tube. And the third thing might be from mucus in the patient's airway. Okay, so now instead of having that water in the garden hose between you and the patient, that water is in, that fluid is in the patient. Okay, so they have mucus developing. So the first thing we're going to do for them, is we're going to turn, cough, and deep breathe, TCDB, right? And then the second thing you want to do, if the turning, coughing, and deep breathing does not work, you're going to suction them. Okay, you never want to suction a patient if they can turn, cough, and deep breathe on their own. If they can turn, cough, and deep breathe, they're going to cough up that material, and you won't need to suction them. You don't want to be doing something invasive when a patient can clear their airway on their own. The second situation when an alarm will go off is for a low pressure alarm. Okay, low pressure alarms are triggered by a decrease in pressure, and they come from two different reasons. Now, you can either have a disconnection. Okay, so now instead of that machine feeling like there's resistance from a kink in the tubing or fluid in the tubing or a blockage in the airway, there's no resistance at all. Right? So the machine says, wow, I'm working way too easy to ventilate this patient. Something is wrong. And so what you want to do is look for a disconnection. Look and see if the tubing became disconnected somewhere. And you want to solve that disconnection problem. We're going to talk about that in a minute. The second thing is there is usually a little O2 sensor line that runs along the tubing, and then it plugs into the tube to monitor the amount of oxygen that's being exhaled by the patient. And sometimes that can fall out, and you won't really notice it necessarily, be flopping around the floor or whatever, and you won't really see that there's a hole in the tubing. So check the O2 sensor line is the second thing that may occur. Right? And these low-pressure alarms on the Nclex, you might see it listed as a low minute volume alarm. Okay, and minute volume is basically the tidal volume that your patient has times the respiratory rate. So it's the amount of air moved in a minute. That's the minute volume. Okay, so if they're breathing X volume at 16 breaths per minute, you would multiply the X volume times 16, and then that's going to be the minute volume. And if that volume over a minute starts to go down for whatever reason, that machine is going to alarm, because the respiratory therapist is going to calculate the appropriate minute volume for that patient, for that client, and set the ventilator at that rate. So if the volume starts to decrease and our patient is not able to ventilate, and not getting the appropriate ventilation, that alarm is going to go off. Let's talk about disconnections in the tubing. Now for the Nclex, if the tubing becomes disconnected and it hits the floor, that means that the patient is not connected to the ventilator. And that means that the patient needs help breathing on their own. So the first thing you're going to do is start bagging that patient. Okay. And the second thing you're going to do is call the respiratory therapist to get a new kit, right? So you start bagging the patient, you hit the call button, and you shout out to get some help from your respiratory therapist to bring a new sterile kit. Now, if the tubing becomes disconnected and it remains on the patient, so it just flops onto their chest or onto the bed, then you can simply reconnect the tubing. Okay, so the germs that are on that patient are their germs, and so if you reconnect the tubing and some of those germs go into that patient's lungs, it's their germs. But when you've been walking around the hospital in who knows what, you have everything on the bottom of your shoes, everything's all over the floor is the dirtiest place, and so if that tubing hits the floor, you need to replace it. Now, in reality, most respiratory therapists would just pick that tubing up off of the floor and reconnect it, because there's not really anything going into the tubing. The tubing is just touching the floor. So let's talk about overventilation and underventilation for a moment. If you have a patient who is in respiratory acidosis, then that ventilator, it may be set too low or too slow. So the tidal volume might be too low or the rate might be too slow. And if this doesn't make much sense to you, be sure to listen to the acid-base relationships lecture. We'll go into this in detail on there. So now if you have a patient who is in respiratory alkalosis, so you have a ventilated patient, you get an ABG, and it says respiratory alkalosis, then the ventilator may be set too high or too fast. So overventilation causes alkalosis and underventilation causes acidosis. So for this Nclex test tip, remember that you need to read each question carefully and consider what are they asking and what kind of information are they trying to garner from you? Are they asking what causes ABC condition, or what does ABC condition cause? So remember, if you have a ventilated patient, that patient is not going to go into acidosis or alkalosis because of some other metabolic condition, most likely. It's probably going to go into acidosis or alkalosis because of a respiratory issue, and we are over or under ventilating them. That's one of the reasons that respiratory therapists draw arterial blood gases, because they need to know whether or not they have a patient in acidosis or alkalosis. So what they'll do is they'll draw that ABG, and if it comes back acidotic, then they know that that patient is underventilating because the acid is building up and not being blown off in the ventilations. Now, if the ABG comes back and that patient is seen to be alkalotic, we know that they're probably overventilating, and we can slow that ventilator down or reduce the tidal volume. And that tidal volume is going to depend on the size of the patient. Obviously, if you have a premature infant who's ventilated, they're going to have a really small tidal volume. If you have a 250-pound man, that patient is going to have a much larger tidal volume. And so those are the things that are going to be adjusted, is most likely first the rate, and then second the tidal volume. Now, what would happen if on that 250-pound man, if you turned down the tidal volume but left the rate high? Well, the lungs aren't going to be fully inflating on each breath, and that increases the likelihood for pneumonia. But if you have too high of a tidal volume, then that patient's lungs can become compromised because you are essentially overfilling the balloon that is the lungs. So if the patient's in respiratory acidosis, then they are likely underbreathing. So underbreathing for a ventilated patient causes acidosis. But if you have a regular patient who's not on a ventilator and they become acidotic, they will begin to overbreathe. So that's the Nclex test tip. Are they asking what causes alkalosis or what causes acidosis? Or are they asking what does acidosis cause or what does alkalosis cause? Okay, so it's going to be the same thing on other topics. It may not be about acid-base relationships or ventilation. It could be about any one number of things. It could be about diarrhea or some other topic. So ask yourself, are they asking what does ABC cause, or are they asking what causes ABC? Okay, so remember, in quick recap, high pressure alarms are going to go off because there's too much resistance, too much pressure building up between the ventilator and the client's lungs. That could be from a kink in the tubing, it could be from water in the tubing, or it could be a buildup of mucus in that patient's airway, in the client's airway. So if there's a buildup of mucus, we're going to turn, cough, and deep breathe. And if they are not able to do that on their own, that's the only time you're going to want to suction. You don't want to suction if they can turn, cough, and deep breathe on their own. If a low pressure alarm is going off, or you may see it referred to as a low minute volume alarm, then that is because there's not enough ventilation going on. There's not enough pressure occurring. So, number one, look for a disconnection in the tubing. And if there is a no disconnection in the tubing, check for a missing O2 sensor line. They're not going to ask you about the O2 sensor line on the Nclex, but that's just kind of for your general information when you're out working with ventilated clients. If the tubing becomes disconnected and stays on the client, go ahead and hook it back up. But if it hits the floor, start bagging the patient and call a respiratory therapist. If a patient is in respiratory acidosis, then the ventilator is probably set too low or too slow. If the patient's in respiratory alkalosis, then the ventilator is probably set too high or too fast. All right? Then when we talk about weaning, you may see that they're weaning a patient off of a ventilator. That means that they're slowly decreasing the use of the ventilator with the intent to discontinue the use of the ventilator. But we got to make sure that the patient, that client, can breathe on their own and independently before doing so. So just as a little puppy gets weaned from its mom, is that process of disconnecting the two relationships. The same thing with your client and their ventilator. Weaning them is slowly decreasing with the intent to discontinue. And that's what you need to know about ventilators on the Nclex. Don't get too deep into this. Don't study too much on the respiratory therapy side. That's why we have them in the hospital. But, you do start to see ventilated patients outside of the ICU. So there you go. Get ready to rock it on the Nclex when it comes to ventilators.